Good evening, everyone. Welcome to this third webinar on COVID management hosted by the Department of Anesthesiology, Critical Care and Pain of the Tata Memorial Hospital in Mumbai. I am Dr. Jiggy Devekia. I'm the professor and head of the department, and I will be moderating this event along with my co-host, actually the chief organizer, a dynamic colleague, Professor Sheila Nayanan Maitra, who will so we've had two previous webinars. One has been on the hemodynamic management and one on the pharmacological and medical management of COVID-19. And this one is focused on the respiratory management of acute respiratory failure in COVID-19. If you recall, there has been a very nice paper which was published in March in Critical Care, March 2021 in Critical Care, which was a Delphi consensus conference on the management of acute respiratory failure. It was led by Dr. Sheila Maitra. Dr. Prashad Nasa from Dubai was the lead author, and many of the persons on this panel were actually on that consensus conference, on the Delphi conference. And so we've got a very star-studded faculty here today, from India and from abroad. And I'll let Dr. Sheila introduce the faculty to you, and then we'll move on with the actual webinar. Professor Sheila.
Thank you very much, Professor Devatia. It is indeed a great honor and great pleasure to introduce such a stellar gathering that we have. I was just going through the CVs of all the speakers, and I think the whole program will just go through if I just read out the CVs. So I'm going to give just a one-line introduction, and I want to tell the audience that we're very fortunate to have such distinguished faculty, and I'm very grateful for your time in the time that you're giving us in this difficult period, and also to the attendees, because it is a difficult time in India now, but to take time out to listen and to learn from the experts. So I really appreciate the time that you are giving. And just a brief introduction, I'll start with Professor Lise Piquiu. Am I saying it correctly? So she is the professor of critical care at the University of Lausanne in Switzerland. And she's also the deputy chair of the respiratory section of the ESICM. We also have with us Professor Laurent Brochard, and he is the director of critical care in Toronto. Just everybody knows Professor Brochard, so really he needs no introduction. Professor Jordi Mancibo, and he's a professor of intensive care from Barcelona in Spain. If you can wave out, please, Professor. And then we have Professor Paolo Pelosi from the University of Genova. He's also a very well-reputed intensivist. And Professor Claude Guérin from the University of Lyon. Welcome, bonjour, and so happy to see you here. And our very own Professor R.K. Mani from New Delhi. And he's also an expert in respiratory failure. So we have real doyens in the field. Without going into details about them, I'll go straight to the discussion on acute respiratory failure. As we know, COVID-19 is primarily a respiratory disease, and there are various issues around this that we would like to discuss. Now, before we go on to the case, I'd just like to start with a bit of a discussion on the pathophysiology of COVID-19, and just like to discuss with the experts, this term happy hypoxics has been used a lot, and we've been seeing patients with very low P2F ratios, maintaining their saturation, able to speak, and with very bad CT scans and x-rays, and yet they're very comfortable. They've been in lay terms called happy hypoxics. So I'd just like to know that what is this phenomena that we're seeing in COVID-19? I think I'll start with you, Professor Jordi Mancibo, if you can enlighten us a little bit about this phenomena. What is this about?
You have described very well how these patients in brackets look happy in spite of quite low levels of PO2, and they are even using the WhatsApp and texting family and friends just before being intubated. But anecdotes aside, I don't know if the term is unfortunate because from a physiological point of view, the sense of dyspnea is elicited at extremely low levels of PaO2. No, meaning that the levels of PaO2 above 50 or 55 millimeters mercury often will not generate a sensation of dyspnea. What it really generates a sensation of dyspnea quite rapidly is the PaCO2. Elevated PaCO2 rapidly elicits a sensation of dyspnea, but often this is not the case in these patients, at least in the acute phases. And there are other mechanisms that have been put on the table to explain this apparent lack of clinical response to low levels of PCO2. And the virus, we do know that is very pleiotropic, and it enters the cells that express ACE2 receptors, which is, and these cells are distributed mainly in all the vascular beds, and also in the nose and some central nervous system parts, and perhaps this may explain the viral alterations at the level of the vessels, perhaps the graphic bodies, perhaps in the central nervous system, that may some way blunt this response to hypoxemia.
Right. Very interesting, Prof. Mansibo, because this is something that we haven't experienced in previous cases with respiratory failure. I think we've lost Professor Mani. I'd like to ask Professor Liz Picu. There was the L type and the H type. In the beginning of COVID, we were thinking about these two kind of phenotypes, and people were deciding on how to manage these patients based on this. What was your take? This was all based on a few observations in a few patients. So what is your what are the implications of this, and what does it mean?
Maybe first the definition of what is a L type and a H type. As you say, it was a description based on the first cases that occurred in Europe, in Italy. And people describe the L type as people with low elastance, which means high compliance, low ventilation over perfusion ratio, low lung weight, and low recruitability. And those patients with the L type are, from at least the first look, not very typical from the usual ARDS we have. Oppositely, the H type are the patients with high elastance, thus low compliance, high shunt, high lung weight, and high recruitability. In my opinion, this difference between L and H is quite schematic and a bit artificial, because it's more complicated than that. And some patients can have a type L in the beginning and then go to a type H. However, this description is important, I think, because it underlines one point that is essential. And this point is that all our ARDS patients are not the same, and that we should adapt the ventilator settings to the characteristic of each patient. This is true probably for PEEP setting and also for other settings of mechanical ventilation.
So excellent. Thank you for explaining this very beautifully. Professor Pelosi, I would like to ask you, well, it's nice to know theoretically about the L type and H type, but what are really the implications for management? As a clinician, what am I supposed to do? Am I supposed to try to find out whether it's L type, H type? What are the clinical implications at the bedside for this?
Yes, thank you. I mean, you know that we were able to measure, and one paper is coming out soon, the perfusion, the regional perfusion and aeration in COVID-19. So we try to really measure what we are discussing. Our model, that of course is open for discussion, is that we have an initial phase that we can define L, whatever we want, but in terms that we have ground glass, so low VAQ. And the reason, in my opinion, and I agree with Jordi on that, of the so-called epihypoxia, that I don't know if it is a correct definition, is that in the traditional RDS, we have hypoxia with low compliance, because we have edema, atelectasis, and shunt. In this syndrome, especially in the early phase, the hypoxia is mainly due to the low VAQ areas, to the ground glass, to the poorly aerated, which is less important. It is not always so true, but in general, less important in traditional RDS. So you have the ground glass are more soft. So the patient does not realize that you have such a terrible disease. While in the RDS, you are more focused on the point. So that's, and then you evolve. I absolutely agree with Imboden that, I mean, there is an evolution, are not two phenotypes. It's just an evolution of the disease. Why this is important? To me, it's very important, because in the early phase of hypoxia, mainly is the role of low VAQ. We measure the dead space and the low VAQ areas. And these are not so different between patients who are maintained in non-invasive rescue support or invasive. And I can tell you even more. We measured the area not perfused in the shunt and, of course, in the dead space, and are quite relevant, almost 1/4, 1/3 of the shunt. So what does it mean? That even microthrombosis that are usually supposed to be very bad, no? And we are, I know that there are some questions then probably on anticoagulation. We are very aggressive, at least some at the beginning, but are partially protective, because you have some microthrombosis in the shunt areas. If you don't have that, you have at least 1/3 shunt more. So to conclude, this is very important. In the early phase, oxygenation is mainly characterized, to simplify the model, by low VAQ. So you can respond at least in part with higher FiO2. At the time in which you cannot respond anymore, so you increase the FiO2, whatever system you are using, and you decrease the oxygenation progressively, very often in hours or 1-2 days, you decrease also the respiratory compliance, you can increase also the respiratory rate. And so you have to intubate. So at the end, I think that the evolution from low VAQ to true shunt in general is the evolution from non-invasive, and then we can discuss which is the best management, to intubation. So that's, to me, is quite relatively easy.
Very beautifully explained by Professor Piquiu and Professor Pelosi. But I put this to Professor Brocha in one line. Can you tell me, at the bedside, what does this really mean to you? And also, the other question to you is, there's always been a debate from the beginning. Is this an ARDS or not? Is it a subtype of ARDS? Because based on this, our ventilation strategies will change. So I want your comments on this L and H type as a clinician to me at the bedside, and whether this COVID-related disease is an ARDS.
Thank you, Sheila. It's really a fascinating topic. So maybe I'll start with the second question. You say, is it an ARDS? And I will answer in 3 ways. First way, the answer is yes, it's definitely an ARDS. Second way, but it shows that we have a problem with the definition. So the problem is not with the clinicians, with whether it's ARDS, it's a problem of the definition.
Right.
And for instance, as Paolo described, you may have a long period where you do not need a ventilator, and it's very difficult to make the diagnosis of ARDS, which is used for clinical trials, but it's still an ARDS.
Right.
And third, and it will come back to the first point, are there specificities? Yes, of course. Of course, there are some specific aspects. This is the first time in the history of critical care that we see hundreds of cases of one single disease, the same etiology. We are not used to that, right? And we see things which probably will make us see ARDS in general differently after, I'm sure. Because I think the the point which has been really, stressed by Luciano initially and discussed before by the speakers, is this dissociation between hypoxemia and mechanics, which we were not used in general. My guess is that it's in part related to the iatrogenic effect of intubation, which by itself create atelectasis, create need for fluid, increase extravascular lung water. So which in traditional ARDS makes everything going together, hypoxemia, shunt, poor mechanics, small lung volume. Here it's different. There is this dissociation, and it's it tells us that we may adapt our strategy when to intubate. That may be really different in this patient than in the classical ARDS in general,
Right.
and how to ventilate these patients.
Right, that's very interesting what you say, that yes, indeed, this is an ARDS. And what we need to do is revisit the definition. Am I right?
Yeah.
Because for the first time, we're seeing a different kind of subtype, but indeed it is an ARDS. Okay, we have Dr. Vani back here. We were talking about this phenomena and the difference that we're seeing in COVID-19 patients. I'd just like you to add on the phenomena of happy hypoxic. So why do you think we get this phenomena? What is the reason for this kind of, is it related to the virus, or what is it?
Sheila, actually the term happy is misleading. Actually, it's an unhappy situation for the patient and for the physician. It's very common that we find bradycardia with the patient of COVID. It's not of much hemodynamic significance, but I think it gives a clue as to what's happening. We know there is neurotropism with COVID. There's some indirect evidence. We are speculating, obviously, why this is happening. The dissociation between the state of affairs and the dyspnea, severity of hypoxia and the dyspnea. There's a dissociation. It's a dangerous dissociation. It's misleading. So there's bradycardia. So something of the autonomic system is affected. And there is a virus can be invading the nervous system as well. We have evidence in the form of anosmia and agusia, which is very common and seems to be very specific. And you do have, people have demonstrated virus in the CSF. And you do get occasionally convulsions, seizures, people presenting seizures and, changes in the MRI. So speculation is that there is some form of neurotropism affecting the autonomic system. I found an article in the Journal of Autonomic Research, all right, where they speculated like this, that there may be involvement of the interoceptive function. Interoceptive means, you have the hypoxia, but you don't get the sensation. You may get tachypnea, you get hyperpnea, but they are not the same as dyspnea, which is a sensation.
Right. So
the blunting of the sensation is happening here through whatever mechanism. And the viruses also enter the heme, apparently. And if they enter the heme, they may affect the dissociation of oxygen, unloading of oxygen in the oxygen dissociation curve. So I think this is it's a cautionary tale that we shouldn't go by the term happy hypoxia.
Right.
Evaluate the patient from the tachypnea, hypopnea, and the hypocarbia that accompanies it, and the work of breathing that accompanies unawares. So we have to have heightened sensitivity to the other signs of tissue hypoxia.
So thank you, Dr. Bani. That's a very interesting sort of theory. And definitely, we really haven't understood the reason why this occurs, but we definitely know that this is a consistent finding that we're getting across patients and clinician experiences. So I'll move very quickly onto a case, and we'll have a discussion based on this. I will just start with this. And again, once again, welcome to all the panelists, and really grateful and happy to have you all here. I've already introduced all the panelists, so I'll just move straight on to the case. So this, I hope you can all see my screen. This is a 65-year-old male. He's a banker by profession. He's diabetic on oral hypoglycemics, and his blood sugars are very well controlled. He's got fever and myalgia since 2 days. He's got 101 degrees Fahrenheit. and he's tested positive for SARS-CoV-2. And these are his labs. His hemoglobin is 12, white cell count is 8,000, procalcitone is 0.1, CRP is 15, and the blood sugar is 110 milligram percent, urea is 34, creatinine is 0.8, sodium, these are the electrolytes that you can see. Now, this patient has been advised home isolation. His vitals are stable. He's maintaining a saturation of 97 and on air, and there's no desaturation on walking. So I'd like to put a question to a poll question, actually. Shania, can we have a poll question? So from a respiratory standpoint, what would you like to do for this patient? Dr. Divatia, would you like to take it from here?
Yep. So this is a question for the audience. I think what you can do is just click on any of the options, and at the end of 10 seconds, maybe we'll get what most of you think, and then we'll put the question to our expert panel. Okay, so just for this patient, from the respiratory standpoint, what would you do? Do nothing, leave him as he is at home, monitor his vitals and SpO2 at home, or even at home, you would have closer monitoring, awake proning, and 6-minute walk test. So start clicking on any one of the options which you think best represents your practice. Okay, I think Hannah, can we have the answers in another 5 seconds?
Oh, excellent. So it's divided between 2 and 3.
Okay. So a lot of people would opt for, about close to half would opt for awake proning at home. So Professor Gore, if I can come to you, what do you think of the role of proning patients in the awake position? And if you do it in patients who are awake and probably not even on oxygen, is there a role for proning, or what do you think about that?
Claude, you're on mute.
Please unmute.
Okay. What we can expect from proning patients like this is to improve oxygenation, because we may have two benefits from proning. The one is to improve oxygenation and to avoid, a death from severe hypoxia or a progression to a management more and more aggressive. And the other benefit will be to protect the lung. But are we really protecting the lung during spontaneous breathing? This is something that we don't know. The thing might be different if the patient is under non-invasive ventilation, for instance. But it is not the case, I understand, because the patient is still at home. But if we think about what is going to happen if the patient is hospitalized and is going to receive, non-invasive ventilation, another benefit from proning might be to prevent ventilator-induced lung injury due to the non-invasive ventilation. But the third benefit, I would say, again, in the setting of COVID, would be to spare the resources in the hospital and to prevent intubation and to prevent admission to the patient to the ICU, and then to minimize the use of the very precious resources that is the ICU setting. That is, but there is a lot of trials that has been done in that field. Some are completed, some are still ongoing. I've seen some results. It looks like there is no effect on mortality. It might prevent intubation, but I'm not aware of the final results of these trials.
Okay. One of the things is, this patient is having a stable oxygen saturation of 97%. And many feel that in order to uncover hypoxemia, which may be building up when the patient is at home, obviously is not being very closely monitored, and X-rays and CT scans are not being done, a 6-minute walk test, something like a stress test for his oxygen saturation, is often advised to pick up impending hypoxemia earlier. So Professor Mancibo, what do you think about doing a 6-minute walk test and how useful it is in a patient who's, as of now, seems pretty stable?
To tell you the truth, we do not have experience in these outpatients, and even less stressing them in brackets with a 6 minutes walking test. So I do not know, not to be honest with you, what's the role in an outpatient, no, the 6 minutes walking test. As far as I know, in patients with acute hypoxemic respiratory failure, there is not much data to for the use of this test in this kind of patients, but I may be wrong.
Okay. Can I come to Dr. Mani? Can you take this question? You see a lot of patients, isn't it, as a chest specialist, and you have teleconsults and you consult on the phone. So what is your view on the 6-minute walk test and all this?
To be honest, I have not used it. You know, I do a lot of teleconsult. I only ask them to check SpO2 and report symptoms, because I don't see anything in the literature to support that we do a stress test. You know, the risk is when you find some hypoxia, any drop, it tends to trigger steroid therapy, which you know, can be ill-timed and premature and you know, not appropriate. So you know, it causes panic. You know, just because it's teleconsulting, you may ask them to do something which may create panic and trigger inappropriate treatment. So we must caution against that as well. So I don't use it in my practice, to be honest.
Right.
And
Perhaps somebody does, and we can have an answer on that and how to interpret it.
Yeah. And while Dr. Mani, while you're asking them to monitor the SpO2, what is your danger value, and when do you tell patients that they should start worrying, talking to, doing the next?
So if a patient has had normal baseline values, you know, there are some people who have had acute and chronic respiratory disease. As I'm a pulmonologist, I do get them. So if there is a drop of more than 2 or 3 from the baseline, or if it's totally normal, drop below 94, all right, that I take as a signal. Because some people take 92, there's some who take 90, but while teleconsulting, I think you must cover for the possibility of you know, change being detected late. So, you know, in that context, I use the cutoff of 94% SpO2. There are times when you get wrong values. You know, one finger shows 96, another shows 94. So that has also happened. So I tend to take the lower value for the reason of safety.
Dr. Pikiu, do you have anything to say on this aspect?
No, I don't see a lot of patients out of the hospital neither, but I can say, or I would like to say, that other respiratory parameters can be very useful. Tachypnea, which is quite easy to look at, accessory muscle activation, intercostal in particular, which is also quite easy to ask the people, do you see something strange with breathing? And dyspnea. Dyspnea, except for those that are really not dyspneic, can be a warning sign. But more complicated tests, I don't know.
Right.
So I think that was a good message here, that apart from the SpO2, we should also look at the signs of dyspnea and tachypnea and so on. Yeah.
So I'll just move to just how this post-patient progressed. He was being monitored at home and he was fine. And on day 5, he continues to have this persistent fever. His heart rate is 110, blood pressure is 120/80, respiratory rate is about 22. And he's been asked to monitor his saturation, and it's about 96 on room air. And he does a 6-minute walk test as advised by his GP. And the saturation drops from 96 to 91. His CRPs have gone up, but other labs are unremarkable. So I'd just like to put this question to the audience first. Shania, if you can have our second poll question, and Professor Divatia, if you can take that.
Yeah, so the question is, now will you admit this patient to the hospital? Yes, no, still continue home monitoring or not sure? So what is your advice to this patient? Okay, please click to correct any one of the options. So he's still 96% sats on room air, but he drops to 91. So 5% drop when he walks for some time. He did some labs and he found his CRP had also gone up. Okay, 5 seconds and then we can have the poll. Okay, so most of you would actually admit this patient to the hospital, and 20% would continue monitoring the patient at home, and just a few are not sure. So I guess the majority would want to admit this patient to the hospital. So let's say we admit this patient to the hospital and he's in a normal hospital ward. He's not yet in the ICU, but ICU beds are hard to come by. So would you advise, and he's of course advised awake proning now because he is on a bit of oxygen and he's advised awake proning. What if he cannot be prone? So let's say he's obese or he's got some problems and he doesn't maintain the prone position. How bad is it, or how problematic can it be in terms of progression or prevent, or this future course of his illness? Dr. Pelosi?
Sorry, but I wanted to make some comments even before.
Yes.
First of all, I can tell what we did, at least in our region, and this is the Italian protocol. We did that. It was suggested always the monitoring of saturation with the 6 minutes. Really, nobody probably do the 6 minutes, but also we call the 2 stairs for 60, 90 seconds. And this, I think, is very important test. And there are studies, of course, not randomized, but we think that is a very important. Second point, the patient has fever, so he should be treated. In our opinion, we treated also patients at home, not personally, but we had a lot of call. And of course, most of our infectivologists, they did this, of course, this job. And antipyretics, very important in this phase. Third, we, at least in Liguria, we are one of the sand areas in the region approved by the national agency that we use in this case. So initial problems, but not so much, the use of monoclonal antibodies. We treated a lot of patients with monoclonal antibodies, and there is also a study ongoing, which is something to think. Fourth point, admission to the hospital. Sorry, but if we would have admitted in the hospital patients like this, I agree that we need a monitoring, we need a physicians, whatever is the organization who kill the patients. We need, we improve the telemedicine in case on that, or contact by phone, which is very important to hear how the patient is speaking, and coughing, because the coughing this patient is very peculiar. It's not the usual cough. But sorry, if you admit to the hospital whatever patient like this, I don't know in India, but in Italy, especially in the high phase of the pandemic, it would be saturated in all the hospitals. So we believe, at least in our region, this was also Dr. Professor Bassetti who organized this. We tried to make some monitoring also outside the hospital. Otherwise, it would be impossible in the acute phase. In the stable, now we have no more almost patients. We are white as Italy, so almost COVID-free. So there is another issue. Regarding the prone position, I did not understand, because I mean, it is a patient with 96, 95 in air. Why we have to put the patient in prone position? What I don't like here is that the patient is going to 91 with the walking test. This is the issue. That makes that this patient, yes, at this point, perhaps we can think, if we are in good condition, to go to the hospital. For sure, this is a patient that has to be considered more carefully. But I think that there are several issues that can be performed also at home. That's what I mean. That I think that excessive, this was under the problem of Italy, at least, especially at the beginning, that we learned that the excessive admission of patients in the hospital this created, at least when we had in the full pandemic, some problems in the organization. So I think that a clear organization, even outside the hospital, is very important.
Right. Thank you, Prof. Pelosi. So the message that you're giving is there's no doubt that this patient needs very close monitoring. And again, depending upon what is the facility you have at home or what kind of step-down facility or whatever you have, depending upon the situation in your country, you would definitely keep this patient in a closely monitored area. I'd like to ask Professor Brusha, are you aware of the COVID-prone study? Because I understand that this is a randomized controlled trial, a big trial that's being done at the McMaster University. Are you aware of it?
I'm aware, but I'm not participating, and I don't see outpatient. And I agree with Paolo Pelosi. I'm really surprised that so many people want to hospitalize this patient, especially in the situation of surge and where you're looking for beds, and this is not a priority. Yes, there is a risk for this patient to worsen, to come to the hospital, but one very specific aspect of this patient is that they do not look like septic patients with the issue of cognition or mentation. They are perfectly well, they understand everything, so you can really rely on them. And that should be a perfect target for family physician. That's really their job. I know it's family medicine and general practitioner is a specialty in danger all over the world, and people send the patients to the emergency room and to the hospital. This is not reasonable. We cannot, our healthcare systems cannot afford that.
Right, absolutely. So I just wanted to ask that a lot of patients are advised proning at home, awake proning at home. Prof. Brusha, at what saturation level, under which situation would you advise awake proning?
I think Claude Guérin very nicely described what we know, what we don't know. We do proning in intubated patients because we think it protects the lungs, so that's the main reason. It has also an effect on oxygenation, which looks good, but we are not sure whether it's important or not. In this patient, what we see is it has an effect on oxygenation, but we don't know whether it protects the lung. So, and the experience we have with proning intubated patients, so not these patients with COVID, is that surprisingly, and I don't think we have enough data, but surprisingly, there are a number of patients, maybe more than the classical ARDS, who do not seem to do well. They don't improve neither oxygenation nor mechanics. And there are some data suggesting that prone may not be protective in these patients. We are not sure.
So that's very interesting, yeah.
So if we come back to the non-intubated patients, we have used it a lot because it prevents decision for intubation because of hypoxemia. But it's not always completely well tolerated by some patients. And so we are not sure. So that's why we need these trials.
Right, absolutely.
Guerre wanted to make a point. He's raised his hand. Professor Guerre?
Yes, I would like to take advantage of this slide to get back to the definition of COVID-19 as an ERDS, because at this point, we are on day 5 of this patient. And we know that from the Berlin definition, we have 1 week to make the diagnosis of ARDS. So in your opinion, are we going to, let's say, suppose the patient is going to worsen, and in the next 3 days, he will be admitted to the hospital. So are we going to consider that he has ARDS at that time because he has respiratory symptoms that evolve for 8 days? It's just, my question is about the timing criterion of ARDS in COVID-19.
Claude, this is why I said we have a problem with the definition. So I don't think the clinician should worry. The patients will have ARDS in clinical terms, but in terms of definition for trials, this is a problem. So I think the definition is not well adapted to these patients.
This condition. Okay.
Can I say that I fully agree with Laurent and Claude that now it's not a problem of the disease, it's a problem, it's the disease
Yes.
of the definition,
The
not the disease of the COVID.
clinician well understands that this is ARDS, but if you go classically by the definition and the Berlin definition, perhaps it doesn't fit in. Okay, so I'll just move on to what happened to this patient. And this patient, again, this is day 7 now, continues to have fever. He's on antipyretics. His heart rate is 114. That's his blood pressure. Respiratory rate is 27. His saturation on room air is now 89. CRP levels have gone up. Other labs seem to be normal. And he was transferred to the hospital, and he started on a non-rebreather mask, and he's on an oxygen flow of 10 liters per minute. Dexamethasone has been started. Low molecular weight prophylaxis is started. And this patient is comfortable and his vitals are stable. Saturation is about 95. So I'd like to, and this saturation is 89. I'm sorry about that. So I'd like to have another a poll question, Shania, if you may, at this point. So what would you do next for this patient is the question. And would you continue the same? Would you want to intubate this patient at this time? Would you like to give high flow nasal cannula oxygen, start non-invasive ventilation, or something else for this patient at this point? He's satting 89 on room air. Shania, are we through? Shania, can we have the results?
Yes, please.
Yeah.
On your screen.
Yeah. Okay, so most of them would continue the same. No one would want to intubate, but some people would want to put this patient now on high flow nasal cannula oxygen. And some people are even suggesting that they would use NIV on this patient. I'll just proceed to what happens. This is his X-ray chest, what it looks like. That was done in the hospital. And a scan was also done for this patient. And you can see this classic findings that you see in COVID-19 patients. And now the patient is progressively breathless in about just a day. And now his saturation has dropped. It's 90%, and this is on the NRBM 10 liters. And the respiratory rate is 33, and heart rate is 118. Blood pressures are 110/88. Saturation is maintained at 94. But he's dyspneic and he cannot complete sentences. So he's progressively worsening. So I'd like to ask you, Professor Brusha. So at this point, would you like to escalate the respiratory support? And if so, what would be your choice? Would it be NIV or would it be high flow nasal oxygen? And what is the role of both of these in acute hypoxemic respiratory failure?
Yeah, that's really the difficult questions we have to face as clinicians, right? So 3 days before, I would have started the high flow. I think it's the problem we say high flow oxygen therapy. It's not so much about the oxygen, it's about the high flow.
Yes.
High flow helps the patients. This is unique in terms of ventilatory support because by decreasing the CO2 in the oropharyngeal cavity, it decreased dead space and it decreased minute ventilation. So this is a very important treatment, I would say. So I would have started the high flow. I'm not sure it would have changed anything. At the point you're presenting here, you say he's breathless, he's dyspneic, he cannot complete sentences. So this patient is going to crash. So the only factor which would maybe make me try something else, if there was another possible indication for non-invasive ventilation, and I see 2 indications. The patient has also associated chronic lung disease, for instance, is a chronic hypercapnic, so maybe it's worth trying.
Right.
Or the patient has obesity, and this has been frequent in these patients. So in these patients, maybe I would try non-invasive ventilation. But the fact that you say he cannot complete sentences, is progressively breathless, I think it's really the best clinical indications we have for intubation.
Right.
Because I think the reasoning is simple. We are not sure mechanical ventilation will be of any help for the lung.
Yeah.
But if the patient is breathless, it will be an assist and help for his breathing.
Right.
It may decrease the work of breathing and the oxygen consumed by the respiratory muscles. So that's an indication.
Right. So very interesting points that you make. So you say that if you had to choose between high flow nasal cannula oxygen and non-invasive ventilation, only if the patient had some chronic hypercapnic disease or he was obese, you would go for non-invasive ventilation. Otherwise, your first choice would be high flow nasal oxygen. So I'd like to put this to Professor Mancibo. What would you do if you had to choose between non-invasive ventilation? He's not got any chronic COPD or anything like that. He's not obese. So what would be your choice? Would your choice also be HFNO?
I essentially agree with the comments by Laurent. You have presenting here a patient that degraded in almost suddenly in 24, 48 hours, even if you gave him anti-inflammatory agent. So it doesn't seem that, at least in the short term, this not drugs did something beneficial for him. And of course, one issue is to start now a high flow nasal cannula, but the patient being that dysnonic and with such an abrupt deterioration, I'm skeptical about using this.
Right.
And just to add only one word regarding non-invasive ventilation. Perhaps if I have it and I have the experience, I would use non-invasive ventilation with helmet, perhaps with moderately high levels of PEEP, because for people having the expertise, especially in Italy, they have shown that they are able to provide a relatively high, or at least permanent moderate levels of PEEP, which possibly are useful in some of these patients, at least in some of them that have recruitable lungs. Possibly with conventional intermittent interfaces, you permanently lose the effects of PEEP, and this is perhaps not good for these patients. If I don't know, if not, I would go for intubation.
Right. So that's very interesting. But I, as I understand, you would both, I mean, the patient is on a non-rebreather mask 10 liters and he's dyspneic. So you definitely want to try HFNO over NIV, except in specific cases. And Prof. Mancibo says that if he has a helmet and he's familiar, people are familiar with using it, then this might be an option. I think one of the concerns with high flow nasal cannula oxygen is when you keep the mouth open, then you lose the PEEP. And it's not very effective for giving PEEP. So perhaps that may be one of the reasons why the helmet may be superior. Perhaps I will ask Prof. Pelosi, because you're from Italy, so you have more experience using helmet. So can you tell us what is the role of helmet? And you have the Hennewatt study now that was published in JAMA recently. So what is the role of helmet and where is the place of helmet in this setting?
Yes, first of all, I agree with Florana and Jordi. So, I mean, I would have started once that it was admitted to the hospital. I also, at the beginning, we did not use too much the high flow because we have not so many machines due to the patients. But actually, we prefer to use the high flow as a first step for exactly the reason that Lorana pointed out. So not only the oxygenation or PEEP, but the question of CO2 washout. and you have a higher respiratory rate progressively, that might indicate that there is an increase also in the probably mechanics, but also the dead space. And then we used a lot the helmet CPAP. I think these were not to be confused by this study in Italy. I mean, we use in Italy in 95% at the beginning, because then we use also the high flow when we had more machine, the helmet CPAP, which is not related to the study. The study was performed in ICU, while the helmet was used mainly outside the ICU. We use the helmet mainly for after extubation like this, but in ICU we intubated the patients mostly. So we used a lot the CPAP outside. So my point is that this can be tricky, because to use the helmet as a positive pressure ventilation, as used in the study, is almost impossible to do in the ward, so outside the ICU. You can do in the ICU with a lot of difficulties, but outside the ICU, we use the helmet CPAP. I don't know if it is, I can say that at least 2/3 of the patient with some quite bad characteristic in oxygenation, at the end we are not intubated. I don't know if this was good or not. We just finished a study in which we look at the patient treated by helmet CPAP for 2 days or longer than 2 days. What we found that the CT scanning, when they required intubation, so it's a specific population, the lung weight and blah, blah, was higher when there was longer time. So again, the time of intubation is question. So we used a lot of helmets, CPAP outside, and now also, unfortunately now not, because we have no
Okay, thank you, Prof. Pelosi. So that's very interesting. So if you have...
But just to say that the positive pressure by helmet is not easy. So you have to do in a very, with people very trained, it's not an easy method.
Okay, so that's very important what you tell us, that it's helmet CPAP is different and giving positive pressure.
Yes.
What was used in the Henny Watt study are two different things. That's compared with HFNO. And you could use a lot of helmet CPAP to probably avoid tracheal intubation in these patients. So if you have it and you have the expertise to use it, you could definitely use it. But what I really liked is all three of you were consistent with saying that high HFNO would be your choice in this acute hypoxemic respiratory failure, and NIV would only be used in specific settings. Now that's very interesting, because as you
Sheila, can I just add?
Yeah, please.
You mentioned the mouth open or closed. That's an interesting question. Right. But I would say the main effect of washing out the CO2 should still be there, even if the mouth is open, right? So I think only it's still the most important effect.
Yes, it's only the PEEP that will be lost, but of course the effect of the high flow remains.
Yeah, and also I don't know, this is something we should study. I don't know why patients decide to breathe mouth open or mouth closed. I think it also has to do with the resistance offered by the system.
Right.
So we have to think of the physiological effect, but also the result of the clinical trials, which now support the use of this technique.
Right. It's interesting you say that, because there is a recent study I saw in critical care where they put a mask over the HFNO cannula, and they actually showed not only was it beneficial from an infection standpoint, but actually the oxygenation was better in the patients who had the mask over. And perhaps it's because with the mask on, they tend to keep their mouth closed. I don't know, but it was a very interesting observation. Now, a lot of people, in India, you've heard of the surge. You heard that we had an oxygen crisis. Now, when you use high flow therapy, you're talking about something above 30 liters. Like you rightly said, Professor Brosha, it's the high flow that makes the difference. So in a place where you have an oxygen shortage, you're running out of oxygen, high flow is not really the best of therapy that you could use. So Professor Mani, I want to ask you that, how much oxygen is consumed when using between high flow and NIV? I mean, which one consumes more oxygen? And from a conserving oxygen standpoint, what would be your take on using either therapy?
I think whatever is appropriate to administer, we must administer.
Right.
And the majority of the time we waste oxygen because we are targeting very high SpO2s.
Right.
And we are allowing very high FiO2s, both of which are not desirable.
Right.
And therefore, I think all the studies, you see, we have a panel of opinion makers on NIV. And all the studies in the last 5 or 6 years have demonstrated clear advantage of HFNO over oxygen therapy, over NIV. So we must integrate that. We don't need to reinvent the wheel. Whatever we have learned from the SAFE study to Florali to the rest of it, we should integrate it. And I would use certainly HFNO, and you can look at it. We just don't look only at the SpO2. Look at the respiratory rate, 33%.
Yeah.
Like Lee said, you must look at the respiration, the respiratory rate, and also any the type of respiration. These are very important, whether it's hyperpnea or not. So I think the question is not about consuming too much oxygen. The question is about appropriate use.
Yeah, I completely agree with you, Professor Mani, because it's not, of course, you have to be conscious of the fact that you have less oxygen. You need to conserve oxygen, and high flow may not be the best of therapies to use in this setting, but definitely you can go down on your oxygen targets, and even the flow that you're setting. You don't need to be at 60 flow. If the patient is comfortable, you can come down to 50, you can come to 40, you can come down to 30. So you can titrate the flow based on the comfort level of the patient, and it's not important to keep everyone at the highest flow setting. So that's a very important question. I just like to move on to saying that, you know, in India, a lot of people, Professor Pikiu, did you want to say something?
I just wanted to add one point.
Yes,
whatever the non-invasive technique you choose at this point, you should be careful to look at the effect of the strategy. And if in this patient who clearly is in respiratory distress, if the non-invasive strategy does not work, you should think to the next step.
Yeah, thank you very much for making this very important point. Whatever therapy and escalation you do, you need to monitor if the patient is improving. And if he's not, then you need to move to the next level. I agree with you. And thank you for emphasizing this point.
Sheila, can I just butt in for a minute?
Please.
So, this about NIV and oxygen consumption with non-invasive versus high flow nasal. I'd like to ask anyone, maybe Professor Brochard, is, let's say you're giving 60 liters flow and 60% oxygen with high flow nasal oxygen. And you put this patient on a non-invasive ventilation, on an ICU ventilator, and with leak compensation and so on, maybe the flow rates may be 100 liters or maybe even more than that. So are you actually, and then you give the same FiO2, aren't you actually going to use up more oxygen with non-invasive ventilation rather than HFNO? I mean,
this is a very good point, very smart. And with the leaks, etc. I think Dr. Mani's recommendation is very important. And again, it's a bit of a misnomer when we say high flow oxygen therapy. That's not about oxygen, that's about high flow. So we can minimize the quantity of oxygen if we have the good targets for saturation. And if we have systems which allow air entrainment, you don't need to target high saturation, I think. You need to target lower work of breathing and dyspnea, and minimize the quantity of oxygen used, which, by the way, may also avoid maybe having hyperoxemic patients, which may be bad. So I think you made a very good point. Non-invasive ventilation may, because of the leak compensation, may use a lot of gas and oxygen, and may not be an appropriate or better technique in this condition. I had a question for you, because I look at the chat a little bit, and so some people say, but the personnel may not be trained to monitor self-proning patients. Some people say, do we have the helmet in India? I think that's very relevant and good questions. And I would like to stress, and I think Paolo Pelosi mentioned that, all these approaches depend to some extent to your own organization. How are you prepared? What equipment do you have? What can you do on the floor? What can you do in the ICU? And this is a collective discussion which should be at the level of the hospital, and which may have different solutions. So there is not one single solution based on evidence, as you have seen. And it depends very much on how can we minimize oxygen, what can we do in which place, etc.
Right. I think two very important points that you made, which I'd just like to summarize. And one is, depending upon your needs and situation and what is your infrastructure available, someone might monitor the patient at home, someone might do an early admission. Helmet is not available in many centers in India. Very few centers have helmet. So you could use it if you're familiar with it and you have the infrastructure. And like you rightly said, depending upon what you're familiar with and the infrastructure you have to make best of a situation in a pandemic. And I think the very other important point, because most people believe that, okay, if I'm on NIV, I'm saving oxygen. If I'm on high flow, I'm using a lot of oxygen. So I think, Prof. Brosha, that's a very important point that you made, that depending upon the patient's clinical condition, the oxygen consumption may even be high on a patient on NIV. And coming to this, a lot of people switched to move to using NIV instead of high flow because we were having this oxygen shortage. And one of the typical things that we were seeing is, and I want to ask you this, is we were seeing patients who were sitting well, very comfortable, but were taking very high tidal volumes. You know, they were on pressure supported PEEP, non-invasive, on a hospital ventilator. And the tidal volumes would be very high, like something like 9 to 10 mils per kg of idle body weight. Now, what is your take on this? I'd like to ask Professor Pelosi first and then Professor Brosha. So this kind of setting, people were worried about these high tidal volumes, you know, a little about PCL, you can tell us. And would you intubate this patient or what would you do? Can you please throw some light on this? Prof. Pelosi and then Prof. Brosha.
Yes, this is the issue also comparing high flow with a positive pressure. With the high flow is more physiological approach because you adapt your tidal volume with all the limitation according to your need. With pressure support, there is a ventilator that is, if the tidal volume is increasing, I mean, if you are in the ICU, you can monitor it, but if you are decreasing the saturation, I would intubate. I don't like to see excessive higher tidal volume once that the ventilator is correctly set in non-invasive positive pressure ventilation. If the tidal volume increases, means that the patient is doing a higher effort. And if we increase the pressure support, we can also have an increase in the transpulmonary because we increase the level of airways, and so then it depends on the inspiratory effort, of course. I know that Laurent is here. The measurement of esophageal pressure, of course, one can do. Some people did, but it's not possible usually when you are in the full pandemic.
And not in the pandemic, yes.
But I would be very cautious if I see an increase in tidal volume. This is then if I can just make a comment just briefly, then because the CT scan that you showed was very interesting. It's a very typical, but I would like to focus on the gray. The focus on the white areas on the periphery. These are very dangerous areas. These are the areas of necrosis, which can make some holes that can lead to pneumothorax. This on the left, you see? I would like to focus on these areas, very typical when the COVID-19 is doing is aggressive on the lung, on the periphery. And these areas can be prone to be break and to make pneumomediastinum and pneumothorax, both in non-invasive or both in invasive. So this is not good for the patient.
Right. Professor Brosha, so my direct question to you first, Prof. Pelosi, would you intubate this patient or will you not? Direct question, yes or no? Tidal volume is 9 ml per kg. He's comfortable, saturation is 95. He's on pressure support with PEEP on non-invasive on a ventilator. Would you like to intubate him? Yes or no?
Yes, but I don't think you mentioned, you say he's comfortable. What does it mean?
Yes,
you say progressively breathless, cannot complete sentences. I would not say this is comfortable.
No, I'm talking about he was put on high flow, but I'm just saying hypothetically, instead of high flow, if you use non-invasive.
Yeah, so Sheila, just to summarize what we have all discussed, I think the big advantages of high flow compared to non-invasive ventilation is that you can decrease the amount of ventilation, which is what you would like to do if the patient is intubated. You would do protective lung ventilation.
Right.
We cannot measure tidal volume during high flow, but the data suggests that they are often smaller. So that's a big advantage. And these patients have a very high frequency of barotrauma, pneumothoraces, pneumomediastinum, etc., which happen before intubation. So you don't want to add on top of that, and especially with the CT scan you've shown, very large tidal volumes.
Right. So what you're saying is this is one of the other advantages where high flow nasal cannula oxygen scores above NIV in this setting. And if I understand correctly, you said you would be cautious and intubate this patient. Is that right, Professor Prasad? With 9 mils per kg tidal volume, though his respiratory rate is...
Yes, and because of the fact the patient is very dyspneic. Yeah.
Professor Gara, you wanted to say something?
Yes, there is something which can be very useful, is the ROX index. I don't know if it's something you use, but it has been shown in many studies that you can predict, the failure or the success in terms of intubation or not of the high flow nasal oxygen therapy. So, and you don't show up here the FiO2, but you can compute the FiO2 from the amount of oxygen the patient receives. There is an equation in the literature that allows you to have the FiO2.
Right. Another question which I want to put to you, and this is, a lot of times we have a patient who's put on NIV. He's comfortable, his respiratory rate has come down, his tidal volumes are fine. But even after 10 days, he's not getting anywhere. Neither is he worsening or getting intubated. And at the same time, he's not getting better. So a lot of people ask this question that, what do I do at this point? We are on day 10 of NIV. The patient is comfortable. I can't wean him off. But at the same time, he doesn't look like he will get intubated. So what do you do in this setting? It's very, very frustrating. So if I can have perhaps Prof. Pikiu, your comments on that, followed by perhaps Professor Claude.
This is a very difficult situation, and we all have those patients, or we all have had those patients. Maybe if he is under NIV, could we try to go back to nasal high flow cannula? We could try. And if it does not work, definitely if there is no arguments for saying that there is an increase in the work of breathing or high tidal volumes, I would say that we should probably keep the strategy and go on with the weaning.
Right. Professor Grant?
I will rule out pulmonary embolism, and also I will rule out metabolic acidosis, because you told us that this patient was diabetic, and I will be curious to see what happens in terms of the metabolic, balance.
That's very interesting, because a very important point that you made, when you see the patients getting nowhere and not improving, you should look for other causes that may be responsible for non-improvement and not attribute this to COVID alone. There are different types of ventilators giving non-invasive. We also have, other apparatus. So Prof. Mani, I'd like to ask you, what are the different types of delivery devices that we have, ICU ventilators, not the ICU ventilators, to give non-invasive ventilation? And is there a difference in the oxygen delivery? If you could just very quickly summarize this for our attendees.
Of course, there's the standalone little devices, where oxygen is not blended, but it is given separately. Yeah. And you have, of course, those with the monitoring facility where you can look at the graphics. But what is recommended in critical illness, hypoxic respiratory failure, is a critical care ventilator being used in the NIV mode. That's what I would recommend. Because you get blenderized oxygen, you are able to ascertain the FiO2 well, you're able to monitor the lung mechanics, at least to some extent. You're able to estimate the end tidal volume. Expiratory tidal volume. So expiratory tidal volume is a very important number. You know, the number 9 we are hooked onto from various papers. So above 9, you have a number to look at, watch for as a to think over whether there is a risk of patient self-induced lung injury.
Right.
Of course, this is a model. Now Dr. Brochard and Pelosi, they have proposed this model, and this seems to be borne out by what we see among COVID patients, because these are the patients more than ever before, any classic ARDS, who've been subjected to prolonged non-invasive support, either as NIV or as HFO. Now, I'm not sure that's the best way to go. Even if it is static, I don't think we should let this go on, because we know from the SAFE study and the insight from the SAFE study of post hoc analysis, we know that the longer you put off, that is, cutoff is 48 hours, in fact. The worse is the prognosis for people who stay on NIV. It is not as bad as those who stay on HFO. But those who stay on just oxygen, mask oxygen, and on NIV, they do worse.
Right.
We may not have worked it out exactly for COVID, but I suspect that there's no reason to jettison all that we have learned with ARDS. COVID may be a little different ARDS in the first phase of the illness, but eventually it gets there, becomes ARDS.
Right.
I'm not even sure
whether
we can continue forever, on non-invasive.
Yeah. So very important points. And I think 3 of the speakers have said that you need to monitor closely on NIV. And if they're high tidal volumes, you have to be careful about barotrauma. And perhaps this is a cue for early intubation. And I saw recently a paper, Prof. Pelosi, in critical care, I think you were one of the co-authors on that, showing that, delaying intubation in these patients with high tidal volumes on NIV may be deleterious, and perhaps patients who are intubated earlier have better outcomes. I'd just like to ask that Prof. Pikilu made a very important thing. She said, perhaps you could even consider going back to high flow. I wanted to ask the opposite question, and perhaps Professor Claude and Professor Brocha, you could both take this. So if a patient is on high flow nasal cannula oxygen and he's not doing very well, he's still quite tachypneic, there's respiratory distress, is there a role for switching to non-invasive ventilation before I consider intubation? Should I just try going on NIV because I can give better PEEP and more, better delivery and compared to HFNO? Professor Brocha, Professor Claude, please take this question.
Well, that's I see that you don't want to intubate these patients, so you're trying everything, which is reasonable, right? Because we are not sure that mechanical ventilation will help this patient. At this point, again, if you need to think how can intubation and ventilation help this patient? It can help by decreasing the breathlessness. Okay, the patient is very dyspneic, and often you have this discussion with the patient and they say, okay, I feel very tired, please help me. So that's an indication definitely for intubation. As I said before, I think about NIV, especially either if the patient has COPD or, which is much more frequent, obesity, because some patients do much better very quickly with high PEEP, so either with helmet if you have it, or even with a face mask. If not, I don't think I think it will only risk to worsen the patient. I think people need to understand the issue with the respiratory drive of the patient. So these patients are usually alkalotic and hypocapnic, which means they hyperventilate, but their brain would like to have even more. That's the issue of the dissociation between the stimulation to the brain, which makes the patient have a very high drive, and the possibility of ventilation. So if you give non-invasive ventilation, you will allow the brain to take more, which may be bad for the lungs. So that's where we are really not sure you're helping the patient by going to non-invasive ventilation, apart from these two indications.
I think that's a very important point that you made, Prof. Rocha. And I'll tell you, this is actually the reality, because people try to avoid intubation, more labor intensive, more ventilators required, and they try to push the non-invasive support as far as possible. Okay, I'll try from HFNO to NIV, or from NIV to HFNO. I'll do something to push the patient forward. But I think this is a word of caution, really, because with this high respiratory drive, you're probably doing more harm by not intubating earlier. Prof. Guerin, can you comment on this, please?
Yeah, I do absolutely agree with Laurence. This is something we will not do in our unit. We will certainly not provide with an IV except for hypercapnia. And there is also something we will not like to do is to sedate the patient a bit, to reduce the drive. This is something we will not do.
All right. So I'll just move to the next slide. So what happened is this patient was put on HFNO, not on NIV. These were just some hypothetical questions I was asking you. He's on 60 liters now. The FiO2 is 0.7. His P2F ratio is 120 in supine position, 160 in prone position. This is awake prone, of course. And his respiratory rate, he's become progressively more tachypneic, and his saturation is now 92. I think we'll have a poll question, Shania, if you could put up the poll question. So this is, he's clearly worsened on high flow. So this is the question that's for the delegates. So if you could just tell us, what would you do at this point? Continue the same on high flow, intubate this patient. This patient was on high flow nasal cannula oxygen. Will you want to switch to non-invasive and give it a try? Or would you want to do something else? Please vote soon. So do we have the answer, Shania?
Honestly.
Okay, so that's very good. I think your message, Prof. Brocha and Prof. Guerin, was loud and clear. And most of the people want to intubate this patient, but there are still a small majority who say, okay, high flow is not working, so I want to try non-invasive ventilation, and they still want to hesitate. But I think that's a very important message that we gave with this high respiratory drive. We probably should be intubating these patients at this time. And which comes brings me to
Sheila, just to be, and it's very difficult. It's a very difficult decision for the clinician, very difficult. So don't feel that there is a right or wrong. But
right.
I would like to stress the fact that I insisted on intubation because of what you wrote. The patient was breathless and could not finish the sentence.
Right.
Okay, because it's possible that the patient we have here on this slide, it's just a matter of oxygenation. Is not in a terrible sense of dyspnea.
Yeah.
It's possible to continue.
Yeah.
And second, it's also possible to continue because you don't have enough ventilators or you don't have enough ICU beds. So that's also another reason.
With a respiratory rate of 35 to 40 on this setting, you would still want to continue on?
Yeah, I don't think the respiratory rate is a very good marker.
Okay. Right.
I would rely much more on the sense of breathless, the use of accessory muscle, and of course the mentation of the patient or cognition.
So that's a very, very good point. It is a gray area and a very difficult decision, especially in India today, because during the surge with the shortage of ventilators and also the manpower required when a patient goes on mechanical ventilation, it's a tough decision to decide whether. So coming to a very important question, and I put this to Prof. Mancibo and also to Prof. Pelosi, how do I decide whether I should intubate this patient? Should I go by the blood gases, the CT scan you saw? Should it be clinical? How do you decide that now the patient needs intubation? Not this patient, but the patient needs intubation. Prof. Mancibo, and then Prof. Pelosi.
Thank you. I think that you have all nicely underlined what's going on. No, the decision to intubate is entirely clinical, 100% clinical. So I think that what's next here in this slide is what's next is intubate yesterday. right? No, because the patient was doing very poorly in the last 48 hours. No, and even though we give a chance with non-invasive ventilation, for instance, because you have good reasons for this. You don't have a ventilator free because you are in the pandemics, you run out of everything, etc. No, you have to be very careful even because sometimes there is a dissociation between the sensation of dyspnea and the amount of tidal volume. So the bigger is the tidal volume, the less is the sensation of dyspnea, right? And this is an extremely dangerous equilibrium as well. It's the same as if you have a patient not under mechanical ventilation and you pretend to minimize drastically the work of breathing. You will almost for sure go to inefficient efforts, for instance, right? So you have to be careful with this. And again, I think that the clinical signs and symptoms are crucial to decide an intubation. And we often just before doing the procedure, we ask the patients if they they really need artificial support.
Right. That's really an important. So you would go purely clinically. You wouldn't go by the blood gases. You wouldn't go by any other criteria, but clinically. Prof. Pelosi.
Well, all these patients are hypoxemic and with more or less degrees of a rapid respiratory rate. Correct? No, I mean that's why we intubate patients.
How do you decide whether to
we decide again putting together several aspects. First of all, if you don't improve with time, the time is gold in these patients, in my opinion. The second, just to remind you, for example, another score that we used is the ACOR score, which includes the pH, Glasgow, PO2, and respiratory rate. Just with two of them, so here the PO2 ratio in supine and respiratory rate, you are more than 7, and the limit is 5. And the Roxy also, I did not calculate it, but for sure it's higher than 5, 6. So oxygenation, I think respiratory rate, I mean, okay, but 35, 40 is quite high respiratory rate. The fact that the patient is not improving, the fact that accessory muscles here is not reported, but I suppose that. And again, here you see in prone position, yes, you can get something, but this can be also a trick for the clinician, because it's, look, the PF ratio improves, so it's better. But this may be further delay intubation. So gas exchange, respiratory rate, the conscience, the Glasgow comments, the conscience, and of course, if there is not activation of other infections, because now we are 8-10 days, so of course the metabolic acidosis of these kind of things.
Right. So important points. So what you're saying is the most important decision is going clinically, looking at signs of respiratory distress, looking for increased work of breathing, and if you see that on these settings, this is your cue to intubate the patient. So you would go more clinically, as Prof. Mancebo said. Now, moving on to this patient, he got, of course, intubated at this point. Perhaps he should have been intubated a day earlier. And I would hand over to Prof. Divatia to take this forward. Prof. Divatia?
Yeah, so this patient was given the standard ARDS net low tidal volume, plateau pressure target of about 30. And the saturation targets about 85, 88%. So Professor Brochard, is that sort of ARDS net strategy, which we've sort of grown up with in the standard before COVID, the BC era ventilation, is that appropriate for this patient, or should we do something else or some other mode? Or
yes, I think it is appropriate, but I think you should titrate it based on the driving pressure, the plateau pressure, etc., because you may have to go below 6, or I don't think it's the case for these patients, but you may have some patients with better compliance where you may allow, sorry, this kind of echo, you may allow higher volumes. So I think it should be titrated based on careful measurements of mechanic, and driving pressure and plateau should be the first things to measure.
Okay. So low tidal volume, control the plateau pressure, look at the driving pressure as well. And
yeah, and regarding the PEEP, so we have designed a simple tool which is a way to assess the lung recruitability, which I think is very useful because some patients are absolutely not recruitable, and you don't want to take any risk by increasing the PEEP, and some patients are more recruitable. So you may go for carefully increasing the PEEP only in those who are recruitable, and also only by carefully monitoring the rest of the mechanics, the PCO2 and the hemodynamics.
actually, that was just the setting for my next question is what sort of PEEP are we trying to give them? And Professor Mancibo, high PEEP, low PEEP, or you have some other way of titrating PEEP for some of these patients? And of course, what is the role of recruitment maneuvers in these patients? I mean, I know in ARDS, we've said especially after the ART study, no routine recruitment maneuvers and so on. But does that hold for these patients as well? So high PEEP, low PEEP, or moderate PEEP and recruitment maneuvers.
So again, in this patient, no, I would start with whatever level of PEEP you decided. Moderate is okay, but again, what is extremely important is to try to individualize, and this means making sure that you use PEEP not necessarily because you have an objective in terms of gas exchange, but because when using PEEP, you maximize recruitment and you minimize over distension. And I think that this is an important concept. And the level of PEEP is to be adapted to these mechanical consequences. So you can have tools at the bedside for doing this, such as that mentioned by Laurent before, which is the recruitment to inflation ratio, which is performing two pressure volume curves at two different levels of PEEP and making simple calculations. If you have sophisticated equipment, perhaps electric impedance tomography can help, as also can help, for instance, the use of esophageal balloons. And with regards to the esophageal balloons, I personally think that these are extremely useful in patients with morbid obesity. I think these patients are extremely complex, and in this particular patients that we have seen a number of them, we feel that the use of esophageal balloons to titrate PEEP, sometimes levels of PEEP even above 25 centimeters of water is extremely useful. But for these high levels of PEEP, you need an extremely close and precise monitoring. With respect to recruitment maneuvers, we in general we do not use it. No.
Okay, so Dr. Pelosi, how do you ventilate these patients?
I agree with what was said. Our experience was that these patients usually don't require excessive level of PEEP, so higher than 15 is very rare as compared to traditional RDS. Our model, I mean, that we developed with our CT data, is that there is less edema in general and more, we can say, consolidation or infiltration, alveolar infiltration. Perhaps in the early phase, just intubated, we use a little bit higher PEEP, so I can say between 12 to 15, but we try to reduce between 8 to 12 within few days. We use prone position But again, we were very careful also with prone position, as also Laurent said, because our experience was that, yes, you can have improvement in prone, but at least a quite large percentage of patients, we had also the same experience. They lose this advantage when repositioned as supine, because we found that at least in most patients, the improvement is always explained by the redistribution and perfusion and not really alveolar recruitment. But so anyway, we used a very moderate setting. I agree that driving pressure is very important to individualize, but I would suggest not to use extremely high level of PEEP. And of sure, I agree also with Jordi, we did not use recruitment. We also published a paper showing that if you use recruitment aggressively, during the recruitment maneuver, you can even a decrease in cerebral oxygenation due to the reducing the cerebral blood flow. So recruitment should be used carefully in general, in my opinion, in RDS, but particularly in COVID-19 patients.
I'd just like to interrupt. We're out of time, but there are a lot of important points to discuss. So if you all permit, if we could extend this by 15 minutes more, if the speakers permit, is that okay? If we could just go on ahead for 15 minutes more? Is that okay with all of you?
And sorry, I want to say lung ultrasound, in obesity is more difficult, but apart from AT, lung ultrasound might be also considered for bedside monitoring.
Right. So I think most of you are muted, but my question was, are you okay to extend the session by 15 minutes? Is that okay? All right. Okay.
Yeah, sure.
Over to you, Prof.
Yes.
Divatia. Just 15 minutes. Yeah. Thank you. Prof. Divatia, please.
Okay. So summarize ARDS-led low tidal volume bladder pressure strategy, moderate PEEP, and then individualized PEEP titration based on driving pressures or whatever other indices for PEEP titration that you may be using, and no routine use of recruitment maneuvers. I think that's so. Professor,
yeah, can I add something, because we have 15 minutes more, so I'm
okay.
So yes, I agree with that. So I see that there was some question in the chat about pressure control versus volume control. We use volume control because we think the monitoring is better. When the patients start to breathe spontaneously, pressure control may be more comfortable for assist, but you have less control of the tidal volume. So the issue of volume control versus pressure control is that just it makes your monitoring of mechanics easier. A big issue we have seen in these patients is that they very often have reverse triggering, which means that they take an effort after the mechanical breath, which can be a cause of double cycling. So this is a difficult thing to manage, because of course you could give paralysis, but you don't want to keep this patient under paralysis for too long. And usually the best solution is to decrease sedation, so to allow this patient to trigger the ventilator. But of course, this is not always possible because of the respiratory drive of the patient. So that's something people should be aware of, and which is a bit complex to manage.
Okay, thank you, Professor Brocha. So, Professor Guerre, now this is exactly right up your street. It was about the prone position, and you're well known in India and of course all over the world for the PROSEVA trial. So when should you start proning? Is it the same like with you? And how often should you prone the patient? I know, we keep them for 16 to 18 hours, sometimes maybe longer, but how many times do you do this prone supine? When do you stop this proning? What is the signal? What triggers you stopping the proning?
Yes, there has been no trials about proning during the COVID-19 pandemic, and the use of proning has exploded during the pandemic, but we have no more level of evidence than we had before. And so we continue to use the approach we had previously, but we had new findings. In particular, there are two large Italian prospective observational studies that consistently showed that the patient responded to prone in terms of oxygenation whatever the response was measured during the proning or after the patient went back to supine, the responder did better in terms of outcome. And we have also had data that are just submitted, not published, that are going in the same way. So maybe this is something new and maybe specific to COVID-19, that the responder to prone could be a subgroup of patients who really benefit from proning in terms of survival, and this is in those patients, prone should be kept on. And the other thing is maybe that the assessment of the potential of recruitment at the time of supine position before proning may indicate that patients who are recruiters will continue to benefit from proning when they went back to supine, contrary to patients who are not recruiter to prone when they went back to supine. So it looks like there are new findings that should be confirmed, but at this time we continue, more or less to use the same procedure, and we assess the winnability of proning when the patient is in the supine position after the session. And as long as the patient has no improvement in oxygenation, we continue proning.
Okay, thank you for that. So that's a very clear answer. You continue proning till the oxygenation, as long as the oxygenation improves. And maybe the prone position helps you identify a subset of patients who might actually have a better outcome if they respond by increasing oxygenation in the prone position. So Dr. Pikiu, let's say the patient does not improve his oxygenation when you give the prone position. What do you do?
I would continue with proning, because proning is not only improvement in oxygenation, but also reducing ventilator-induced lung injury and has a lung protective effect. Then at least in our unit, we continue even if there is no clear improvement in oxygenation.
So this is open to anyone. At what stage would you bring ECMO into the picture?
As a rescue therapy.
Only
really rescue.
So if your patient failed proning, would you go on to ECMO?
If he's very severely hypoxemic, I would consider it. But that means a PF under 60 probably. Okay. But also because we don't have a lot of ECMO available during the pandemics.
Right. So of course, everything's going to be dictated by availability and in our country costs and so on. But you would still go for ECMO only if the patient was very severely hypoxemic. Okay.
I'd just like to ask one question. So presume that ECMO is available and we're not in the midst of a pandemic. And, in this setting, you would not consider starting it below a P2F, above a P2F of say less than 80, or can anyone comment on that further? I mean, would it be P2F ratio?
Yeah, I think the ESLO criteria should be followed. If there's a response or trend towards response with prone positioning, we may use several cycles. We can go on for days, and many have got rescued that way. Another thing may be just to understand the lung mechanics a little bit, try and find if it's recruitable or not by short recruitment maneuvers, and looking at the RI ratio popularized by Brochard and rest of many and Pelosi. So if you can look at that and see that the recruitability, the patient may do better with a higher PEEP. Now the more severe category may do better with a higher PEEP of the PF of the ratio, odds-net ratio, the higher PEEP level can be used. But sometimes what happens is you need to find an ECMO-enabled center. In India, all are not ECMO-enabled. So you may want to transfer the patient in time to an ECMO-enabled or transplant-enabled center. Then you may have to transfer the patient on ECMO, transport ECMO, rather than on precariously on a ventilator with a high FiO2 and high pressures. So you may protect lung a little bit by by a little earlier ECMO, but according to the ESLO criteria. Of course, you have to have a PF ratio for a certain level and other criteria.
Right. Prof. Rosha, when would you decide ECMO? I remember seeing this very nice paper, French guideline. I think it was published in Annals of Intensive Care. I think it was a very nice guideline with a nice graph.
So, yeah, so there is a paper published in the Blue Journal recently, which is the nationwide experience of ECMO in Chile. And the paper is interesting because they capture every patient, every COVID patient and every ECMO. And okay, you could say maybe the indications are not, but they follow the EOLIA criteria.
Yeah.
And the indications was 1% of intubated patients. 1% of intubated patients. So I like ECMO. I think it's a fascinating technique, but don't think that it should be right away in the. So you need to have the facility to do that. You need to have the way to transport the patient. There are a lot of limitations. And remember, it's only 1% of the population. Some countries have used much more ECMO. They have much poorer results. They have very high mortality. So I think it's not only a last resource technique, but the selection of patients you have, ELSO say 65-year-olds, many centers say 60, and no comorbidities, no frailty, etc. So it's a very risky technique. Again, I like it very much, but you would tell me we don't do ECMO in India, I would say that's okay. You will not see a difference in the overall mortality rate.
That's a very important point you make, Prof. Rosha, but because actually the centers that have it use it a lot in India and use it much earlier also in India. So it's interesting that you say that you would only use it purely as a rescue therapy, even if you had it. And it doesn't mean that if you use it a lot, the outcomes are going to be any better. So careful patient selection and purely as a rescue therapy is the real message for using ECMO, whether you have it or not. So in the interest of time, I'll just proceed further. And I would like to just ask, and this patient landed up having pneumomediastinum. So I'd just like to ask that we're seeing a lot of pneumothoraces, a lot of subcut emphysema, a lot of pneumomediastinum. So I'd just like to ask Professor Mani that, is this more in COVID? And why are we're not only seeing it in ventilated patients, but we're also seeing it in non-ventilated patients. So why is it more in COVID?
I think this COVID situation has witnessed very prolonged NIV and non-invasive therapies. And the pathophysiology changes from first week to second week, from good compliance to a poor compliance. And then there is this self-induced injuries, which we can only guess at, we are not quantifying. I think it's got to do with the lung mechanics.
Right.
The stiffer the lung and more the tidal volume, in relation to the stiffness, you get higher incidence of pneumomediastinum or pneumothorax. And this is a pretty common with spontaneously breathing patients. This we have not seen before with earlier ARDs.
Right. So that's very interesting. You think it's related also, partially to the therapies that we're using. I'd like to have Prof. Guerra's view. Sometimes you just see a pneumomediastinum. The patient is not ventilated. What should we do? Should we put a chest tube in this patient, or should we just monitor? Is this self-limiting, or should we worry about it?
You mean before intubation?
Yeah, just before intubation. We see sometimes a lot of pneumomediastinum. So how do you handle this in a non-intubated patient?
With non-invasive ventilation, or
yes, non-invasive.
I would avoid non-invasive ventilation. Actually, we have seen some pneumothorax in COVID-19 patients, but we have seen also more patients than before COVID-19. And this is when the patients were under non-invasive ventilation. We didn't see patients with a pneumothorax under HFO, but I would obviously minimize, the pressure, the transpulmonary pressure by any way.
So I would like to ask you that if this happened in a ventilated patient, just a pneumomediastinum, would your ventilatory strategy change?
Yes, sir.
Test you?
Oh, yes, we will definitely, sedate the patient. If not, if he was not, maybe paralyze the patient and reduce the tidal volume dramatically and optimize the respiratory mechanism monitoring, certainly.
So I want comments from Prof. Rocha and Prof. Mancibo on this. So, how what is your take on this? Prophylactically putting in a chest tube or, ventilatory settings in an intubated patient who develops a pneumomediastinum. Either of you.
Sheila, I suggest this is not the real X-ray of the patient.
No, it is not. It's not. It's not.
Or you have a miracle treatment, which we should all know about. So no,
this was just
I am saying that because in patients with ARDS in general, and the lung, is so already injured and condensed, and that you almost never see a complete collapse of the lung.
Yeah.
And even if you have pneumothorax, it's usually very small pockets of air. When you measure the pleural pressure gradient, as researchers have done, like Paolo, like we did, there is a big difference in the pleural pressure between the dependent part and the non-dependent part. And in the dependent part, the pressure is very high. So there is very, very little risk that the lung collapse. It's only collapse in the non-dependent part. So I would monitor, of course, but
will you put in a chest tube? Will you put in a chest tube?
No.
No? Prof. Mancibo?
No.
Would you manage this patient?
No, neither. Only close monitoring.
Okay. So what you're saying is usually the pneumomediastinum is self-limiting and it settles on its own. And that's a very important point because of the lung condition of the lung. Very rarely do you see big pneumothoraces that need an ice chest tube. So just careful and close monitoring. And as Prof. Guerin said, perhaps sedating the patient, reducing the tidal volume, and monitoring the pressures is what is required. So I'll just hand over to Prof. Divatia. You can just proceed just the last 1 or 2 points about this case.
So just now, let's assume everything's gone well and the patient seems to be getting better slowly but surely. So is there any specific weaning strategy? Or just do you do it the normal way we wean? So what do you prefer? Someone who's been ventilated like this for 12 days, do you prefer just a TP trial, or do you want a gradual pressure support weaning, or Spain versus France, or what sort of strategy would you have? Professor Mancibo?
That's an extremely good point, and perhaps here that the patient now is at 0.5 and PF 225, so I suspect the PO2 is very good, but perhaps many think that the patient is still not winnable, right? So that's why I would do the ATP trial when I think that the patient is not winnable right away. So just disconnect for 1 or 2 minutes and measure the F over BT. Or if you do not want to disconnect, you just leave your patient in the circuit, in the ventilator with a CPAP 0, fully monitored. And if the F over BT is below 100, then you have to disconnect and proceed not to extubate if the patient, he or she is tolerating this no spontaneous breathing for 30 or between 30 and 120 minutes.
Dr. Picchio?
If not, I would go to pressure support ventilation and decrease the levels of support according to tolerance.
Dr. Picchio?
I would use SBT with 7 pressure support and 0 PEEP. But what is probably the most important during the weaning phase is to be sure that our COVID-19 patients do not have still high respiratory drive. Because if they have, there is a risk of worsening, new worsening of the situation, then I would definitely monitor what I can at the bedside, PO1 and occlusion pressure.
Can I have just a comment? Just to remind the problems that this patient can have in a prolonged weaning. Usually these patients, they stay between 7 to 10 days longer than traditional RDS for neuromuscular problems, because they are doing a neuromuscular blockade, corticosteroids, and so on. And the second, I would recommend the role of physiotherapy, respiratory physiotherapy, which is essential in critically ill patients, but I think especially in this type of patients in the weaning and after extubation.
Right. And again, continuing with you, Prof. Pelosi, about tracheostomy, what do you think is the right timing of tracheostomy? I know you were part of this
Yes.
study that was done on which said 10 days, and have things changed? I mean, are you going to do tracheostomy based on particular number of days?
I mean, we just finished a large Italian study, which is probably to be accepted in a short few days. And we found that the median time was 15 days. So we compared the patients longer and shorter. There were no difference in terms of different outcome parameters. And there were also some patients, especially at the beginning, they underwent surgical tracheostomy compared to percutaneous, but these patients, they had more infection, as we know. So at the end, we preferred to try, if possible, according to the clinical status, an extubation attempt and eventually tracheostomy. So we were not on average for very early tracheostomy. So we maintain it again around 10 to 14 days,
right.
A little bit later, yes, in this patient.
Would it be correct if I said that try to extubate the patient, and if not, do a tracheostomy as it is required in which you would do in non-COVID patient, and not after any specific number of days?
Anyway, we almost, except few cases, we never perform tracheostomy within the first week or 10 days.
Right. Prof. Divatia, any few last questions if you have?
I think we just quickly, just talking, we have seen many patients who have something like a chronic fibrosis or a BOOP kind of picture. And some patients remain dependent on oxygen. So Dr. Mani, what is your experience, and what do you advise? Do you advise home ventilation after a point, or do you advise home oxygen? And Dr. Mani, for our guests from outside the country, Dr. Mani is the equivalent of Charles Sprung as far as end-of-life care in India is concerned. So what is your view on end-of-life or your experience of end-of-life decisions in these patients? Dr. Mani?
So briefly, of course, some progress to a chronic stable sort of hypoxic failure. I agree. Some of these are like BOOP, organizing pneumonia, as evidenced by biopsies done in a very small number of patients, and also by previous experience with H1N1 ARDS and aftermath. So some of them do well with low-dose steroids over a period of time, and there is no indication to use antifibrotics. As far as I know, there's no study done specifically to prove antifibrotics stop the progress. They don't have any effect on resolution of fibrosis, of course, as by previous experience in other diseases, particularly idiopathic pulmonary fibrosis. So I would say that you could try a low-dose steroid over a period of time. Some of them do resolve either with time or with the anti-inflammatory treatment. As far as the end-of-life issues are concerned, a lot of them do have on a background frailty or chronic lung disease, and they are not expected to do very well. So we must do a conversation with the family wherever possible about the goals of therapy. Goals of treatment are very important. We want to conserve the resources, ICU resources. We want to also not compromise on the dying and dignity aspects, because they've gone for a six. In a pandemic situation, the human side of medicine has been heavily compromised. So many of them die alone and without a family for many reasons.
and they are not even accorded a very dignified, death. So goals of treatment have to be set. They have to be reconciled with their own values expressed before, sometimes with advance will, which has become allowed now in India since 2018. Some of them have got sensitized, and they may not have executed a formal document, but they might have expressed their wishes with the immediate family. So I would say there should be a heightened awareness of patient wishes and values, and what a patient would like to do, where the ceilings are of treatment. And finally, I must say, conversations may be difficult, but they are more important in a pandemic situation, because the psychological side of trauma to the patient and the family has to be integrated in our thinking.
Right. Professor Divatia, if you could just wind up the session in the interest of time, if you could just summarize what we just discussed today, and then I think I'll ask the speakers for some key messages.
I think we've had a very fascinating session. We've had a lot of physiology, pathology, pathophysiology being discussed, and also very core clinical points on management of respiratory failure in this in COVID-19. And we've had a perspective from all over the world, from the top experts in the field. And Dr. Mani has given an excellent perspective on India and on end-of-life care, and communication, which is taking a big hit during this pandemic. So I think we'll just move on and ask all our experts to give a short.
So I would just like each of our speakers to just give one or two key messages that you think is very important in the management of acute respiratory failure. I'll start with Prof. Mancibo, and then I'll go to Prof. Pelosi, and we'll move on. Prof. Mancibo.
Okay, thank you very much. Okay, I think that now we have seen an epidemic of IRDS, and now more than ever, we have realized how heterogeneous and complex is the disease. And the corollary is that we need, above all, to individualize all our treatment, which, by the way, if not done properly, can be dangerous for our patients.
Okay, so individualized therapy. Prof. Pelosi.
Yes, of course, I agree on that. And then I would add, accept low saturation, don't delay intubation when needed, and be organized, be multidisciplinary, and use local guidelines in order to be always prepared for an event.
Very, very good. So don't intubate too early and not too late. So intubate at the right time. I think that's important. Professor Mani, what is the message that you would like to give the delegates?
I must say we are, as Dr. Mancibo said, that we are witnessing a pandemic and an epidemic of ARDS. So we must integrate all the knowledge of traditional ARDS and try to integrate that into the management of COVID, atypical ARDS, which may seek into typical ARDS at some point. So it depends on the phase of the illness. So we should not forget the lessons already learned in the last 30 years of treating ARDS.
Right.
So the added, I must say, one thing added here is the possibility of self-induced lung injury. And so just looking only at the oxygen saturation, VO2 alone is not enough. We must integrate the patient effort that is being needed to maintain that level.
Very important point. So there are new lessons learned, but we shouldn't forget our basics and the research that's done over the last 30 years in management of ARDS. I'll go to Prof. Pikiu and then Prof. Guerin, and then we'll end with Professor Prosha. Over to you, Prof. Pikiu.
I would also say, as Professor Mani, that protective ventilation should be performed in all our COVID-19 ARDS patients. And I would add that clinical evaluation really helps, from home to ICU, and from deciding whether intubate or not up to weaning. And this is probably something that is coming back in our practice and comes again in the main area that clinical evaluation is important, even for intubated patients.
get back to your clinical monitoring of the patient. This is very useful in COVID. Prof. Guerin?
I think it's very important to have recommendations to follow, and we were very happy to have them. And it is important to follow these recommendations when they are reasonable, and also to be clinician at the bedside and to integrate these recommendations.
Right. And finally, over to you, Prof. Rocha, to give us your key message.
Well, very difficult to add something clever here. I would say be a good clinician, and which means work closely with your nurses, with the personnel, the team in the ICU, with the patient and with the family. So that's very important. And on top of that, be also a smart physiologist, not reasonable one. So trying to think of the clinical constraints and apply that for the individual patient. So thank you. And thank you for the webinar today, Sheila, and the opportunity to have this fantastic discussion.
Excellent. And thank you so much for the extra time. I think we had a very, very good discussion. I've gone through the chat. There's not a single question that has not been addressed in the management of acute respiratory failure. I hand over to Professor Divatia to wind off the session. Thank you, delegates. Thank you, all of you, for the extra time that you have given us. Professor Divatia.
Thank you very much for joining us today, all the delegates, and especially our experts from India and abroad. I think you've given us benefit of your knowledge, your wisdom, and your time, of course. And I think the one thing that stands out is look at the patient, be clinical, don't forget the basics, and use whatever we've learned in the last so many years, apply it to the patient at the bedside. Don't forget your physiology, but remember there's a new pathology you're looking at. And I guess at the end of the day, we still have, at least in India right now, we are still in the midst of a pandemic. We are getting better, but we are still seeing a large number of patients. We have to deal with resource constraints imposed by the pandemic, but use whatever we know and apply it within their limited resources or whatever resources you have, and for the benefit of our patients. And at the end of this, we'll all meet one day in person when all this is all over, and hopefully we'll share lessons that we've learned and pat ourselves on the back for all the good things that we've done. Thank you very much for joining us. Thank you very much for your time, and hope to see you all.
Thank you, Sheila and Jiggy. Thank you very much. Thank you,
Thank you so much.
co-panelists.
Thank you so much.
Thank you.
Bye.
Thank
Thank
you.
you very
Bye.
much. Bye.
Everyone. Bye-bye.